I am Laurel at the Ivy Business School. The work I'm going to be talking about today was funded by Western University through a COVID-19 Catalyst grant. We call the program that we're doing Leveraging Pandemic for Digital First Healthcare. I've worked with a number of people, their names are here. What also was interesting to me was Dr. Kathy Falds was involved in the project that was just presented as well. So we have a very interdisciplinary team and quite a few research assistants from around the university working in this project with us. Today, I'm focusing on a particular aspect called an expert model of pandemic triage decisions. And we are using this model in our work as a framework for the rest of our research. And in particular, looking at the study of patient navigators during pandemic. And so in the last talk, we also heard about navigation of the healthcare system. So another overlap there. Let me just turn off. Sorry, I'm trying to fix my screen here. All right. So before I tell you about the research question, just a couple, I think the audience is probably familiar with these, but for those of you who are not, patient navigation is providing a person or a system, could be software, to help a patient navigate the healthcare system. And the main purpose of this navigator is to eliminate barriers to timely diagnosis and treatment. And so one sort of natural patient navigator is our triage systems. So if you call your family doctor or if you go to the emergency room, you are first and you encounter someone who asks you some questions to sort of rate what risk level are you, how do we prioritize you within the system, who do you see, when do you see them? Digital triage, of course, then is when we digitize that, when we use software to emulate the decision-making process of that human being. Typically, we're doing this when we're thinking about triage on a mass scale. So for example, in time of pandemic, and the system uses if-then logic to make decisions that would emulate what the human triage provider does. So at the start of the pandemic, we observed that there were digital self-triage tools for COVID-19 deployed throughout Canada. Every province and territory created their own. So if you're here in Ontario, I'm sure you've encountered the Ontario self-assessment tool. If you were in New Brunswick, the tool that you encounter looks very different. If you're in Quebec, the tool looks very different again. The three don't look like each other. So these have been implemented in a variety of ways. So we were wondering, well, what can we learn about the use of patient navigators and the potential benefits, costs, harms of such tools from the sudden unexpected implementation of digital COVID-19 patient navigators across Canada? What can we learn about this for digital first healthcare going forward? So that's sort of our broad research question. So what can we learn from these patient navigators that suddenly appeared and that we were all being asked to engage with? Some of the ongoing research activities within our research program are first creating this expert model of triage decisions to frame the research. And that's the focus of what I'm talking about today. So what's very interesting to me in hearing the last presentation was the focus was on the broad healthcare system. My focus is much more today on the individual decision maker who's making decisions within this system and understanding all of the factors that potentially influence the decisions that they make and how that has impacts on the individual or the healthcare system. We're conducting a scoping review of digital pandemic self-triage tools. We're doing a longitudinal study of the 13 self-triage tools across Canada. So like I said, every province and territory has their own. We took snapshots of each of those at, I think, 4 points in time over a 14-month period to see how they evolved, how they were changing. And one way we can assess that is by using the kind of expert models that I'm going to be showing you today. And then we did do in-depth interviews. We finished those about a year ago with 20 people in Ontario, so residents who are living in Ontario, and 13 family doctor providers, family care providers, about their experiences with and perceptions of self-triage tools. Some of the advantages of online triage, you can probably think of some, but as you read the literature, the ones that really stand out, first of all, they're easily updated. If there is, and you've experienced this as we go through the pandemic, science updates pretty quickly. There can be changes to what we're advising in terms of triage for pandemic virus as the science, as we learn more. It is much easier to update one software system and hit sort of send, and it deploys to everyone who's using it, as opposed to needing to update hundreds or thousands of human triage providers so that they are up to date with the latest science, know what the current recommendations are in terms of triage and so on. So they're much more easily updated and deployed on a massive scale. They should, provided people have access to the technology, they're available at any time, at any place. So this does facilitate access to healthcare. People don't have to necessarily leave the place where they are to get care. So as long as people have the resources, it should be better, easier access, so more efficient from a systems perspective, and hopefully offering more equity in terms of access to care. Third, these kinds of tools are really intended, the main focus, the main intent in developing these is to reduce demand on the rest of the healthcare system. Because of course, in time of pandemic, and especially early in the pandemic, many people were concerned and wondering, should they be, were their symptoms representative of COVID-19? Should they go to their doctor or to the hospital and be triaged to see what they should do? Do they need care? What kind of self-care do they need? Should they be concerned? So to the extent that many people in time of pandemic are probably worried and can be told, you don't need to worry, just take care of yourself, or B, be told, well, you might have to worry, but right now you can self-care, things don't look too bad, you can just stay home. That reduces demands on the triage providers in our brick and mortar facilities where we normally provide triage. So lots of reduced demand on the healthcare system. This relates to the next benefit, which is reduced viral spread. The fewer people we have going and sitting in waiting rooms and talking to health providers, the less risk there is to exposing the health providers to the pandemic virus or to other people in the waiting room. So reducing viral spread is one of the objectives of introducing these tools to the system. And then finally, because we can collect data on a grand scale, there is more opportunity for monitoring and surveillance. And so triage systems have always input information to the public health system to use for monitoring and surveillance. It's aided, right? That's more efficient when we have things digitized and lots of people creating data that we can then use to track hotspots or identify trends or predict demand. If we see what's going on now with the pandemic in our system, what do we expect to happen in a week or in 2 weeks, given what we know about this particular virus? So the method that I'm using today to model this system in which the individual makes a decision is it's a systems approach to understanding risk situations. And it's a method that was developed within an interdisciplinary mental models approach to understanding risk situations and risk decisions that people make. So my focus is very much on the individual making a decision, but often when we think about decision making, we think of it as, well, you weigh the pros and cons, the potential costs and benefits, the potential harms, and you make the optimal decision. Real people making real decisions in the world make their decisions based on their mental models, right? Their beliefs, their set of beliefs about the decision at hand, which isn't necessarily just the pros and cons of the two alternatives that they might be facing. So there's lots of things that influence the decisions that we make, including, of course, our knowledge. What's in our mental models? What are our beliefs that might be accurate or inaccurate? They might be complete or they might be incomplete. So the method, the modeling that I'm talking about today really comes from this study of individual level decision making, recognizing that when we make decisions, it's within a very complex system where lots of things are influencing us, and the decisions that we make and that others make have influences on other parts of the system. So what I'm talking about is modeling expert understanding of this risk situation. So what are the factors and actors who are relevant to this individual's decision? What do experts believe are consequential pieces of information that might impact a person's decision. What are the expert hypotheses about relationships among the various factors in the system? So we're looking, just like in the last presentation, at a wide range of experts to understand their beliefs. So we're looking for breadth. What are all of the factors that might be relevant to this decision? What are the interactions between them? We're not looking for depth. We're not trying to become experts at how viruses propagate or how people are exposed and sort of the effects on the human body. We're not looking at that, but we do want to understand the breadth of factors that experts believe are relevant to this decision. In modeling this, of course, there can be disagreements and uncertainty. Certainly with any nascent science like a new pandemic virus, as we're starting to explore it, to understand it, to study it, scientists disagree, and we see things changing over time. So early in the pandemic, we were concerned about exposure via droplets in the air that we might get if somebody coughed or touched something. Now we're much more exposed about particles in the air. So things change over time. And you might have these sort of uncertainties and within the model that you're developing. As I said, often the interest is decisions by individuals, and that's what I'm looking at today, focused on this individual decision maker within a system where they're making decisions. So we use a systems approach, typically depicted with an influence diagram. So it's a different kind of modeling than we just saw a few minutes ago. And we start by eliciting expert belief from the literature. So we take a dive into a wide range of literatures to understand this risk situation. Then we typically will review the model that we've created with experts. So either one-on-one interviews or having a panel or having maybe a 2 to 4 hour workshop to understand from their perspective. And these can be academic experts, very applied experts, people from a wide range of domains. Are there gaps in our model? Are there errors? Would you validate this model? Is it something that we can go forward with? So the kinds of literature we examined, we looked at a lot of academic publications. We looked at things like public health websites and explored a lot of different topics related to pandemic virus triage. So how are pandemic viruses transmitted? What are risk factors? We looked at symptoms and risk factors for COVID-19. Looked at vaccination and testing. What are factors related to triage quality? What is digital self-triage? What are the impacts that it has? What is advice in times of pandemic, the relationship between triage and care? So all kinds of things. So we really read a wide range of literature to understand triage decision-making and the triage system. Some of the things that we learned, just to summarize, it will help sort of give you sort of a context for the model that I'm going to be sharing. So this is straight out of mental models, thinking, cognitive psychology. I'm a behavioral decision theorist. I study how people make decisions. What are the things that influence decisions? What are the things experts think ought to be influencing decisions? Not what decision should people make, but what's the consequential information that they should be considering, so we can design communications or interventions to help improve informed decision making. So that's kind of the perspective that I come at this from. So people's decisions are informed by their beliefs and mental models, the set of information that they believe is relevant to the decision at hand. Health beliefs are influenced by health risk communications, which often come from care providers or public health agencies. Availability of triage is affected by government policies. People seek triage not only because they're concerned about symptoms, but also because they're concerned about exposure. Triage quality depends on the ability of the provider to incorporate new knowledge as it is generated. Receiving appropriate care depends on the quality of triage and the quality of the advice that's given, on the person's actions and their ability to follow that advice. Do they have the knowledge? Do they have the resources to do that? Appropriate care depends on test results if tests are provided, which of course depends on whether tests are available and the quality of the tests. Appropriate care depends on having the treatment and resources available to enact whatever advice has been given to our individual. As demand on human triage providers increases, there's a lot of impacts, of course, on the system. So economic costs increase. So time of pandemic, if we have lots of people needing triage, that of course there's economic costs, human resource costs involved with that. The risk of exposure to healthcare workers and others increases. We might need more triage spaces, so we might be putting up things like tents or taking community centers to provide triage. Resources for other care decreases as the healthcare workers are inundated with people seeking care, and triage fatigue grows, which can reduce triage quality. As more and more people are seeking triage, wait times increase and people might decide to leave and not even get the triage that they were hoping to receive and potentially then follow on care. And pandemic triage is an important source of data for surveillance, monitoring, and prediction. So I'm going to be presenting this expert model in the form of an influence diagram. So it's another visual sort of way to model a system. If you're familiar with decision trees, you will see some similarities here. So we have decision nodes shown as green boxes. And so that's the decision made by the focal actor. So here I'm focused on the individuals who are seeking triage within this system. Yellow nodes represent other stakeholders, other actors in the system who have an influence on what the person experiences. Blue nodes are chance events. These are factors that can take on different values, more or less. So as you are more exposed to the virus or less exposed to the virus, or as you have more or fewer risk factors, that's going to affect the severity of disease, for example. So every node in the system has a factor that can take on different values. The diamond-shaped nodes are outcomes, the outcomes of interest to us in this system. And the arrows are very important. They depict how factors influence each other. So as the value at the tail end changes, the value at the head of the arrow changes in a predictable way. So as I experience more exposure to the virus, I'm more likely to contract the virus. As I have more risk factors relevant to this particular virus, the more likely I am to have severe disease if I contract the virus. So the arrows really represent expert hypotheses about relationships between factors in the model. So I'm going to start with, I call this a high-level expert model of pandemic triage decisions. So we have our individual in the center who's making triage decisions. We have this pandemic virus. So I'm going to walk you through this model, how we understand this kind of model. So we have this pandemic virus that enters our system, which prompts public health reactions in terms of policies, actions, communications, and so on. And I'm focused here on triage. So of course, they're doing lots of things, but I'm focused on triage. That virus also, of course, you can't be exposed to the virus unless it exists. So we need the virus to exist in order for anyone to be exposed. So the public health agency starts taking actions, some of which relate to making triage available. And at this point, I'm looking at traditionally what would be available. So clinicians, physicians in clinics, maybe telemedicine, emergency rooms would be our traditional means of triage. The public health providers communicate about the pandemic and triage. And those communications influence the mental models, the beliefs of our individual. Those mental models and beliefs always within decision-making, we take the perspective that our decisions are informed by our beliefs and mental models. So what does the person believe that's relevant? We come with existing mental models to any new situation. So those mental models influence, we'll be talking about the individual's care decisions in a minute and their decisions about triage. So we have the health providers affecting what happens with triage and communicating about that so that our individual can make triage decisions. The individual can only decide to seek triage if it is available. So we have this influence here. They're likely to seek triage if they believe they've been exposed to the virus or if they've contracted the virus or potentially contracted the virus and have symptoms that are representative, that they believe are representative of that virus. So those would influence these decisions about seeking triage. As the person, as this individual seeks triage, of course, they influence the amount of demand on triage providers, and it's going to depend on which provider they choose, where there would be more or less demand. Demand on these providers, of course, also depends on what other people in the system are doing with respect to seeking triage. as the amount of triage, as demand on triage providers increases, well, we talked about the impacts of triage on, so there's more costs. As there's higher demand, there's more costs. There's potential exposure to the provider and others. There's the need for additional triage providers, perhaps, if demand gets really high. And it's going to impact what resources we have for other kinds of care. As demand increases on providers, it also, we find, can impact quality in a negative way. As demand increases and people can't even get to triage, for example, that's a decline in quality. If wait times are long and they leave, that's a decline in the quality. Quality of triage depends on the ability of the triage provider to incorporate new knowledge into their algorithms, their decision-making algorithms, by which they help the person navigate in the system. So the quality of the triage and the advice given is going to influence this person's behaviors, and it's going to influence whether they receive appropriate medical care, which also, of course, depends on providers being available, treatments being available, people knowing what are the options they have in terms of self-care and so on. And then we see that depending on the kind of care that a person gets and how appropriate it is, whether they're ill or not is going to influence whether they expose others. And then these influences, these outcomes at the bottom, the individual's health outcomes and demand on the healthcare system. So this is just at a high level. What are the main factors that are relevant to this person's triage decisions? So when they're thinking about what they're going to do, of course, they're thinking about, do I think their mental models, do I think I've been exposed? Do I think I have symptoms? But also, what do I know about where these triage providers are? Where can I go? What are my understanding of what they tell me and so on? So there's a lot of information in here. This next slide simply adds, well, if we now add digital self-triage to the mix in terms of availability of triage providers, then of course, now the individual, if they know about that, has a new option for seeking triage. And in doing so, to the extent that lots of people do that, that affects, as we said, demand on sort of the brick and mortar triage providers, with all of these various impacts then on the healthcare system. Or it might be that we sort of don't have those impacts on the healthcare system because we've reduced demand. Then, just like in the previous presentation, we take a deeper dive into the factors that are relevant to the person's triage decisions. And I don't have time to go into all of these today, but over here we have factors relevant to contracting the virus. We've added testing for the virus. Is the test available? What are the results and so on? But what I do want to just sort of point out are the things really relevant to triage quality. And so we see a lot of things. So whether the person can enact the decisions, so seek triage depends on their resources. Quality of your mental models, the person's understanding of this virus and the questions they're being asked is going to influence the kinds of responses they give. Do they give the accurate responses? Because we aren't always able to do that. That's going to influence triage quality. So demand on triage providers influences quality. So does the responses the person gives. The responses they give depend on the questions that they are asked by the triage provider. The questions they're asked depends on what do we know about this virus and what we should be doing with respect to triage, and the provider's ability to incorporate that new knowledge into their own algorithms. So we've got the quality of the triage algorithms. We have the quality of the person's responses. We have other triage provider resources that's going to affect whether they're available and the quality of the triage that they provide. And now when we add digital self-triage, of course, now we've got the influences of technology and developers and their ability to put these new algorithms or this new knowledge into this digital patient navigator that we're now offering to people. One of the things in the model you'll see is there's this contract the virus, of course, is important. It influences if you have symptoms and therefore seek triage. I'm not going into this next model. I just wanted to sort of show you that we have developed an expert model of the influences on contracting virus. And there's lots of stuff relevant to that, of course. So the non-pharmaceutical interventions, are people aware of them? Where do people spend time is really important to whether you're exposed and contract the virus. That's influenced by what all kinds of organizations and the government public health agencies do. So lots of factors relevant to contracting the virus. So we can develop our expert model at different levels, go deeper and deeper, depending on what we're trying to do and what are the decisions that we're interested in for our individual decision maker acting within the system and the influences on themselves and the system, more broad system. In terms of the interviews that we did, these were done, we finished about a year ago. So I'm just going to touch on this very high level. Respondents were not very aware of the provincial triage tool, but self-triage tools had entered our system. The government, in fact, required it, right, for all employers to do screening before you go into the workplace. Hospitals use them, doctors' offices use them, schools use them. Everybody's screening everybody all the time. People talked about this fact that responses have become rote. You just say no, 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 click send, and you're done. People's desire to enter or to not enter a place therefore motivates false responses. So this came up in many of our interviews, reflections on people's own behavior. I wanted to move into the dorm. I couldn't respond in the screener that I had a sore throat because maybe they wouldn't let me move into the dorm. Doctors telling us, the patients answered the screeners. They said they didn't have any symptoms. Then they walk in and they say to me, well, I want to talk to you about this cough I had, right? And so the patient didn't understand that the doctor might be screening to understand what kind of PPE they should use when they're talking to that patient. So these misunderstandings that lead to things that we don't want to happen. Some people did believe that they were using the provincial tool for those kinds of screenings. But what sort of came out of this as we read through the interviews, our preliminary, and these are our preliminary thoughts on this, is that by using these tools in so many places, in so many ways, it's become it isn't a patient navigator anymore. It's a navigator for entry into the school, into the workplace, et cetera, which potentially limits the value of these tools because people think about them in a different way. It's become quite mundane. So if we look at our expert model, what we find through the interviews is, well, the government, in fact, not just the public health providers, but the government in general, told all of these other stakeholder organizations, you should be screening people. That influences people's decisions. What goals come in mind? I want to move into the dorm. Therefore, I'm going to think about the responses that I give, which influences the quality of triage, and therefore impacts, am I able to access those places that I want to spend time? But of course might also influence other things like exposure to others. So in terms of conclusions from where we are at this point, we've got a lot of work we're working on related to this project. But in terms of conclusions and thinking here about this conference, expert models provide a way to frame our research to think about the individual within a system. And what are all of the factors that are relevant and consequential to their decisions? And how does that influence the greater system that they are working within? It does help us, I think this was mentioned in the last presentation as well, it helps us remove researcher bias. It helps me to think about what are all the things relevant to the system, not just what are the one or two things I personally as a researcher really find fascinating. It helps us visualize how a change in policy or a change in stakeholders, a change in practice sort of kind of flows through the system and has ramifications for other actors or other parts of the system. It can help us explain sort of the risk story that we face and draw conclusions from that. And then in Ontario, sort of this wide use, this required use of self-screening everywhere we go has potentially led to sort of a shifting, you might say, of these patient navigators to be something that they weren't initially intended to be, and has potentially actually reduced the value of them for people's use, because people might see them in a different way than they would have otherwise. The Ontario triage tool would keep up with science. The ones that employers are using might not. but people don't really know the difference. They think they're all the same. So that is potentially not a good outcome as a result of that. So with that, I don't know if we have time for questions, but if we do, I'm certainly open to questions that people might have.